Okay, so now in this second part of the diabetic talk, we're going to talk about the medications and treatment for both type 1 and type 2 diabetes. Now, obviously, the biggest thing, type 1 you can't prevent, but you can identify early, and you can keep really tight glycemic control, meaning you want to keep those numbers, oh, I don't have it up here anymore, you want to keep those numbers between 80 and 100, and you want to keep that A1C less than 7%, because the tighter control that you can have on those blood glucose levels, the fewer the complications you're going to have down the road. The nerves and the cells don't love to be floating around in way too much sugar. That's what starts causing the complications, the neuropathies, the retinopathies, things like that we'll talk about later. But that's why you need to keep really tight glycemic control. In your type 2 diabetics, although we do have a lot of medications that we can put them on, different classes of meds, it is essential that they understand the importance of weight loss, a reduction in BMI, healthy lifestyle, and exercise. So even though we're going to start the patients on some medications, especially the type 2s, we're not going to underestimate the power and the importance of good nutrition and healthy lifestyle. So teaching becomes very important. So we're going to start out with the insulins first, and these are always, always, always for your type 1 diabetics. These oral medications, they're not going to help your type 1 diabetes, because the oral medications all have something to do with either increasing insulin production in the pancreas or increasing the absorption of insulin, or glucose and insulin, things like that. Well, if you don't have any insulin, these aren't going to work. So sometimes your type 2 diabetic will also need insulin, and especially in times of stress, when they go into surgery, when they're in the hospital, your stress levels go up. Anytime you're stressed, your cortisol levels go up, and that's a steroid that increases blood sugar. Anytime somebody is on a steroid, you also have to check their blood sugar when they're in the hospital, because steroids, even natural ones like cortisol, can increase blood sugar. Don't forget that, because a ton of your patients are going to be on steroids to help promote healing of one type or another. You have to keep a little bit tighter control on their blood sugar. And this becomes even more problematic in your patient who has known blood sugar problems, like in your patients who have diabetes. So sometimes your type 2 diabetic patients, when they come into the hospital, they'll be on their oral antibiotics and they also need an insulin. But your type 1 diabetics, they might need more insulin, but the type 2 drugs are not going to be effective in helping reduce blood sugar in your type 1 diabetics. Something to keep in mind. Okay, so one thing I want to point out, first we're going to talk about the kinds of insulin. It is really important that you understand the different times of action of insulin, when your patient got it, and when they ate. This is really, really important to understand. And there's an excellent table on, it's table 51.3 on pages 14, 28, and 29. You need to spend a little bit of time understanding this table. Here's why. There are basically 4 different types of insulin, and by types of insulin, I mean when they start acting, when they peak, and then how long they stay in the system. That's really important for you to understand, because you're going to be giving these insulin, and insulin is always an injectable, a subcutaneous injection, so it's always going to go sub-Q. You can't take insulin orally. You can put somebody on an insulin drip, IV, but they can't get it orally. So there's 4 different kinds. Rapid acting or very short acting insulin, the onset of action occurs very rapidly, within 5 to 15 minutes. So if you need to get somebody's blood sugar down stat, you can give them a rapid acting insulin. You need to be careful if you give somebody a rapid acting insulin when they're going to eat, because you can't give them a rapid acting insulin and then have them eat 20-30 minutes later, because it peaks in about an hour and then it's out of the system in about 2 or 3 hours. So you need to keep tighter control on that. Your short-acting insulins, these are like your regular insulins. These will start working within an hour to an hour and a half. They peak within 2 or 3 hours, and then they're usually out of the system within 4 to 6 hours, about the time that the patient is ready for a next meal. And these are really good insulins to do meal coverage. So they kind of, and you'll notice, see the second one down where it says insulin, all of them are insulin effect, where you see that rapid acting insulin. Those are often used right during meal time. So somebody might give themselves, they'll check their blood sugar in the morning, and then they'll give themselves their their short acting insulin, like their regular insulin, so it can cover their breakfast or lunch. Now it depends on how brittle, if you've heard of like a brittle diabetic, that means somebody that their blood sugar is all over the place and it's really hard to control. That's a brittle diabetic, and they might need more often blood sugar checks and more often insulin regulation. Then your intermediate acting insulins, these are going to start working within 2 to 4 hours. Their peak action is between 4 and 12, and then they're usually out of the system, usually within about 24 hours. These are good for your continuous all day, just insulin maintenance all day. And then you have your long acting, which they start working in about an hour, and they're out of the system in about 24 hours, but there's no peak. It doesn't kind of spike up. It just stays constant. These are more like your basal, BASAL, your basal insulins. That's kind of your steady one. Typically what happens is, and again, depends on how bad the diabetes is. Typically your patient will get a combination of the two. And a lot of the insulins now come pre-mixed, so they'll have a little bit of regular insulin and a little bit of either an intermediate or a basal insulin, and you'll see this as like MPH 3040. 3070, so it'll be 70 units of like a short acting or like an intermediate, and then 30 units of regular or something like that. So it's important to know when you're giving your patient insulin that it's Ryan! What? Can you stop? I'm recording. Sorry, my son's home. So it is important to know when you're giving your insulin, what kind of insulin, and when your patient is eating. This becomes problematic and a little bit more tricky for the nurse if you are if you need to make your patient NPO, if this patient is going to surgery. Now all of a sudden you've reduced the glucose amount in the bloodstream. So now what are you going to do with that insulin? So it really requires a little bit tighter control. Often what they'll do in the hospitals and when you're in your clinical settings, look at your unit's policy. Most of them will have a policy in place so that it will say if the blood sugar is between here and here, give this much amount of insulin, and typically it's regular, because the regular insulin is the short acting, and you can just cover it, and then you can recheck the blood sugar and cover it that way. So I would recommend that you guys know this table, and the other thing that is good to know is the different, like MPH, glargine, regular. I just want you to understand these different types of insulin. It's also important, and your book mentions this, to know if the insulin is cloudy or clear. Some insulins are cloudy, meaning they look like watered down milk, and that's normal, but you need to understand it, like, is this insulin supposed to be clear or is it supposed to be cloudy? Because if it's supposed to be clear, like a regular insulin is supposed to be clear, and you go in and find out that it's cloudy, don't use it. It's probably gone bad. Most of the insulin now are synthetic, but some insulins can be pulled from bovine or pig insulin. Insulin can stay out at room temperature for about a month, so you can get a big block of it on your unit, but if it's not going to be used for a while, it needs to stay in the refrigerator. The other thing that it's important, if the patient doesn't have like a pre-mixed vial, a lot of the insulins now come in pens and it's pre-mixed, so that then the patient learns to give themselves an injection with a pre-mixed pen. If they don't have that, it's really important for them to consistently draw the insulin up the same way. So for example, if they're getting a regular and an intermediate, it's important for the patient to pull up to draw up the regular first in the syringe and then pull up the long acting or intermediate acting. So then when they inject it, the intermediate acting is injected in the subcutaneous tissue first, followed by the regular. Some studies are saying that it doesn't matter, you can draw intermediate first and then regular, or vice versa, but the important thing is consistency, that the patient does it right, which can get a little bit tricky if your patient is elderly or confused, because worst case scenario, you don't want them like drawing up regular insulin and then drawing up more regular insulin when they think they're drawing up intermediate, because they can give themselves way too much insulin and then bottom out their sugar. The other thing that it's really important to keep in mind is that you have to use an insulin syringe. In the United States, we have 100 parts of insulin per milliliter. So if you look at the insulin syringe, it's broken down into the units, and it's just easier to draw up. The syringes are a little bit smaller, because if you're using a regular syringe, even like a 1 cc syringe, it's easy to get way too much in there. And again, you give somebody else too much insulin, you'll bottom out that blood sugar very quickly. So those are some things to keep in mind regarding insulin. There are some complications to injections. They can develop some scarring, some fat dystrophy, kind of things like that. You can read about that in your book. The other thing I do want you to study in your book, you know what, never mind. I'm going to tell you that when we talk about complications. There's two complications. One's called the Somogyi effect and one is called the Dawn phenomenon. I want you to read about those in your book. Both of those have to do with when the patient is sleeping overnight. Now you've gone, 8 to 10 hours with no food. So depending on what those insulin levels are doing, they can bottom out their blood sugar very easily. And sometimes it will spike, like right around 2 or 3 in the morning, because of the normal sleep cycles and hormone releases through the night. And then it'll bottom out. But it's important to know if it's a Dawn phenomenon or a Somogyi effect. And we'll talk a little bit more about that when we're talking about complications. And the treatments are different. So if somebody's having a Dawn phenomenon or a Somogyi effect, you need to either have them increase their bedtime snack, and most of your diabetics, your type 1 diabetics, have to have a bedtime snack just so they have some kind of food through the night, because most people will have dinner, anytime between like 6 and 8 p.m. And then we tell most healthy people to not eat after dinner, because if you eat too late and then you go to bed and your metabolism slows down, then that contributes to obesity. But in your type 1 diabetics, they can't go that long. You can't go from like 8 o'clock at night eating your dinner till 8 o'clock in the morning. Now you're at 12 hours with no glucose at all in the system, and then they tend to spike at night and then bottom out. So they either have to have their insulin timing adjusted, or they have to have a snack in the evening right before they go to bed. By a snack, I mean healthy snack. We have them having, a piece of fruit, or like something with fiber in it, or like a piece of toast with peanut butter on it, or something like that. Okay. On page 1431, you'll see this is what some of those pre-mixed pens that I was telling you about. And a big nursing thing is to teach a patient how to inject themselves. It's very scary for a person to have to start injecting themselves with needles. And a lot of times now, what patients who need to have really tight glycemic control, or young children that are running around during the day and they can't stop and give themselves injections, is a lot of patients now we can install pumps. And the pumps are becoming much better now. They're implanted into the subcutaneous tissue, and they have a little like a reservoir on them, and then many of them will either just deliver continuous insulin throughout the day, and some of them now are good enough that they will also test the blood sugar, and then they can figure out how much insulin to release. And it just goes right under the skin, a little bit like an IV. You know how when you put an IV in and then you pull the needle out, and then there's a catheter in there. The catheter is just kind of rubber. It's like that, but in the subcutaneous tissue. And then it can stay in a certain spot for, you know, a month or so, and then they have to change spots. But those are really good for continuous insulin control. And I think your book talks about, yeah, on page 1432, you can see there's a picture of one of these insulin pumps that I was talking to you about. So I want you to know that for type 1 diabetes. Type 2 diabetes, they have insulin. Their pancreas produces insulin, so they don't need the insulin. What they need is something to help the efficiency of the insulin. There's basically 6 categories for the oral medications that we use for our patients who have type 2 diabetes. The sulfonylureas, that's this first one up here, they're really common. What the sulfonylureas do is they stimulate the beta cells in the pancreas to squeeze out more insulin. So basically it's just smacking the pancreas like, come on, let's go, let's get that insulin out, because the pancreas is starting to get tired. So that's what the sulfonylureas do. And some of your sulfonylureas would be like gliburide, glipizide, things like that, and I'm sure you're learning about that in pharmacy. The biguanides, the way that those work is, you know, in the liver does this process called gluconeogenesis, and it is one of the producers of glucose. So when glucose levels get too low, the liver will, you know, produce more glucose in this process called gluconeogenesis. Well, the biguanides stop that process. So the biguanides really work on the liver, and it halts the gluconeogenesis in the liver. These are great drugs. The one that you'll probably recognize is metformin. Metformin is a biguanide, but because the biguanides work on the liver, you need to be really careful for your patients who are going to CT scans with contrast, because the contrast gets metabolized also through the liver, and it can cause liver toxicity. It can cause problems in the kidneys. So typically your patient who's on type 2 diabetic and they're getting metformin, you have to stop the metformin for at least 24 hours before that IV contrast, switch to something else. They might need a little bit of insulin here, and then get the CT scan, then let the contrast flush out of the system, usually 24 hours. Unless their kidneys aren't working, then it might be a little bit longer, and then you can restart them on metformin. But keep that in mind. You get an NCLEX question for sure, because they want to know that you know how to protect your patient from CT contrast in the face of metformin. The next thing is the alpha glucoside inhibitors. These drugs interfere with the absorption of glucose in the GI tract. They're not as commonly used, they don't work as great, and they tend to be a little bit more expensive, so you're not going to see a ton of those in practice, but some physicians still write for that. Then the glitazones, this long one, this, I never say it right, thiazolidinidinones, that's a humongous word. Those are insulin sensitizers for the cells. So what this category of drugs does is it increases the sensitivity of the cells to insulin. So it basically is increasing the effectiveness of the insulin that's already there. These are like Avandia is one. A lot of these have been pulled off the market because the complications of them and the side effects of them outweigh the benefits. So many of these actually are no longer on the market. Then the which one are we on? Oh, I already did this yet. The non-sulfonylurea insulin secretions, like these would be like the maglanotides. Those drugs release counter-regulatory functions of the pancreas. So you know the pancreas has a lot to do with when you get hungry, and it tells your brain this person's hungry. So these drugs tend to counteract that. So it makes a person feel full sooner. It makes them less hungry less often. So that's what the non-sulfonylureas do. And it kind of also, they can stimulate the insulin secretion. These ones are pretty similar to the sulfonylureas. They have a similar kind of mechanism of action. And the these are the difference here. The non-sulfonylurea insulins, they're all the drugs in this category are branded. There's no generics, meaning they're expensive. They're very expensive drugs. They are injectable, so these ones are not oral, like a patient might inject themselves a couple times a day. Really good for overweight patients. But some of the side effects of this are pancreatitis. It can lead to some pancreatitis. So okay, so I think that's it. Like with the oral drugs, sometimes there is a combination. Like I said, sometimes you can use both, like the Byetta and pamlintide. That's like an adjunct therapy. They can be used in combination. I do want you to know, page 1433 down here at the bottom, figure 51.5. I really like this chart down here at the bottom because it shows you what the different kinds of the oral drugs do, where they work, and most of them have like a primary and a secondary action. So you can see where they work and on which system. Like, is it on the pancreas? Is it on the reception end? Is it on glucose absorption, insulin secretions? So that's a good one for you to understand where in the system these different oral meds actually work. Table 51.6 on page 1434 and page 1435, that'll tell you the names of these different drugs and what class they're in. You should know that. Those are really, really important drugs to know because everybody and their brother is on them, especially like the biguanides and metformin, the glucophage. Yeah, so know those because that's something you got to know as a nurse. Okay, so I think I told you about that. Long-acting, short-acting. I told you about that. Okay, so I think that's it. I think that's it for the medications. Then we're going to talk about complications in the next thing. So, all right, we'll go. This is a lot, and we'll go over it more in class. But you do really need to start understanding the drug therapy and the pharmacological therapy in our treatment of type 1 and type 2 diabetes. Okay?